Good. Good.
Okay, so I'm going to start. So we're going to speak today about kidney, which is otherwise known as acute renal failure, and sometimes is used interchangeably, but more and more people are referring to this, syndrome, I would say, as acute kidney injury. So very briefly and basically, it involves the suppression or cessation of normal kidney function, so that renal regulation of internal homeostasis is compromised, and when it's acute, it's so strange that like my back is turned to the big screen, but hopefully everything is transmitting. When it's acute, it's happening within hours to days, and the great thing about acute kidney injury is that it's potentially reversible. Most of the time it is reversible, right? As the patient gets better. With chronic, it's more gradual in onset, months to years, and unfortunately not as reversible, and most of the time progressive. So back in the day when I was training, and imagine how old I am, we did not have a classification system to define acute kidney injury. And I remember when I was a fellow, when the AKI group met, and I did a search for definitions of acute renal failure, and I found 35 different definitions. So clearly there was a need to classify the definition of acute kidney injury. And so the AKI group were a bunch of nephrologists and critical care specialists that came together in a beautiful town in Italy. And they discussed how to classify the definition and came up with a RIFLE criteria, which is an acronym. And the first three letters, risk, injury, and failure, simply is more severe, low severity, high severity definition based on serum creatinine and based on urine output. Although nephrologists don't use the urine output criteria by itself, we usually either combine the two criteria or really just solely rely on serum creatinine. And if you can see, the risk classification is the 1.5 time increase in serum creatinine. GFR is problematic in this definition. I don't recommend using it on its own without a serum creatinine. Injury is 2 times the baseline serum creatinine, and failure is 3 times the baseline serum creatinine, or a serum creatinine greater than 4 if there's a acute rise of greater than 0.5. Loss and end-stage kidney disease really is talking about duration, and these are mostly outcomes, but just for you to know, loss is over 4 weeks. Acute renal failure and end-stage kidney disease is over 3 months. This has big implications actually for payers, because if you go from a diagnosis of acute kidney injury, acute renal failure to end-stage kidney disease, you then qualify for Medicare and you're automatically covered for all of your expenses. So this is a big transition point for payers out there, but not relevant to what we want to cover today. So as you can see, the RIFLE criteria was further modified by the Acute group, another bunch of nephrologists and some critical care folks who decided to get rid of the loss and end-stage renal disease classification and make it 3 stages, the most severe of which is stage 3, obviously. Otherwise left things pretty much the same, but look, they got rid of the GFR designation, because that really doesn't make sense in an acute renal failure setting. GFR is not really relevant. You don't use GFR when someone has acute renal failure. It's really for CKD. So they got rid of the GFR classification, and look, they added this designation of if you have an increase of 0.3 milligrams per deciliter in your creatinine, you make the diagnosis of stage 1 AKI. Now you would look at this and say, are you serious? You see patients coming in going from a creatinine of 0.6 to 0.9 all the time. They have AKI. Well, according to the AKI criteria, they do, but there is a time window that they have to make that increase within, and that's 48 hours. Okay, this became a really big deal for us because we were studying COVID-related AKI in this hospital. And we wrote up our manuscript, and we only used the 1.5 times creatinine criteria. And a lot of the reviewers came back and said, what about the 0.3 milligram increase? And all of a sudden, our AKI incidence went from 43% to 56%. So you have to be very careful about these definitions, and it could be potentially misleading. We ended up staying with a 0.3 increase and reporting 56%. Anyway, so if any person ends up on renal replacement therapy, they automatically meet criteria for stage 3. Fine, and this is the KDIGO criteria. These are really the guideline people in the kidney world. And they basically go by the AKI criteria that I just showed you. This is just restating it. And some people use urine output criteria. It's not really recommended to be used on its own. So what about acute kidney injury? Some history. In the 1800s, they thought that uremic poisoning and oliguria was the result of urine mixing with the blood instead of coming out of the urethra. Interesting perspective, maybe not totally off the mark. During the bombing of London in World War II, acute kidney injury or acute renal failure was first described, and these were injured crush victims during war. Obviously, mortality was devastatingly high. So what did these people have? Rhabdoids. Excellent. It was during the Korean War that hemodialysis was first used for these patients, and the mortality decreased significantly. And rapid fluid resuscitation of injured soldiers in the Vietnam War showed that you could decrease the incidence of AKI, much less need to treat the AKI in these patients. So people were understanding rhabdomyolysis and how it caused ATM. This is Mozart. He actually is purported to have died from acute kidney injury with a severe form of post-strep glomerulonephritis and rapidly progressive glomerulonephritis. I'll show you that differential in a minute. What about incidence? So it occurs in about 5 to 10% of hospitalized patients in the United States, up to 40% of patients in the ICU. Mortality, when it occurs on the medicine ward, although maybe not so much monthly, it's about 5 to 10%. Mortality in the ICU is up to 70%. That has not changed in 40 years, much to our frustration as nephrologists. Across the world, you can use the KDIGO criteria that I just showed you, the classification system, and you can see that overall about 23% of hospitalized patients get AKI. And here's the breakdown by stage, and 2.3 have dialysis requirement, 2.3%. Keep those numbers in mind, because the last slide I'm going to show you is our experience with COVID and how many patients had stage 3 AKI requiring dialysis. Now, obviously, this data is not completely reliable because it really depends on sampling and who's being reported and what they're using in the different hospitals and who they're reporting to. But overall, it looks to be about 20 to 25% of hospitalized patients get it. What happens when you do get it? I know this is a very morbid slide, but more and more we're realizing in the last 15 years that if you get a bout of AKI, it's highly associated with risk of death. So back when they came up with the AKI criteria, the same critical care author actually did a study looking at the ability of the AKI criteria, or the right criteria in this example, to predict short-term mortality in the ICU. And as you can see, with each graded increase in severity of acute kidney injury, there was a much higher mortality, 60-day mortality. So in this sense, you can even use these criteria to predict short-term mortality in a hospitalized population, in this case in the ICU. Well, what about long-term mortality? This was a study of a lot of people, about 1 million people, and what they did, it's a big database study. They looked at patients that were hospitalized here. Can you see my arrow? Mm-hmm. Okay, good. And what they did is they compared those people who did not get AKI during this hospitalization to those who got the different degrees of AKI during the original hospitalization. And what they were able to show is survival was much significantly less in those people that had about an AKI here. And this was regardless of whether they recovered, how bad the AKI was. As you can see, this is not as statistically significant. So clearly AKI has a very high association with long-term death. What about with CKD and dialysis requirement? This may seem obvious to some of you, but as you can see, with about an AKI in the original hospitalization, you have a much higher risk of CKD progression. to ESRD, and this is costly not only to the patient, but to our society. I included this table because I just want to introduce the idea that we really don't know the diagnosis with AKI, we pretend we do. Sometimes we see muddy brown casts on the urine and we know it's ATN, sometimes we don't. But it really is an educated guessing game, you know, don't tell the other nephrologists I told you this. But, you know, the different etiologies that this will go through are really our best estimate. We don't have a good test to see exactly what's going on, and we can't biopsy them for obvious reasons. So when you think about the differential diagnosis of a patient with AKI, you really want to break it down. I know you saw this in medical school into pre-renal causes, intrinsic causes, and post-renal causes. Don't get hung up on this classification. It's really to organize your brain around the differentials. The intrinsic causes, the most common of which is tubular necrosis. It can be ischemic or it can be toxic. Okay, the most common is ischemic. You also can get interstitial nephritis from various agents or from infiltration. Acute GN is much less common because frequently it's not bilateral, or if it does cause AKI, it's usually in someone who has a solitary kidney. And then you also have to appreciate that classification schemes are really for us to be able to organize our thought process, right? Actually, what's happening to the patient as our patients are getting older with more comorbidity is that there's this vicious cycle of AKI feeding into CKD, feeding into AKI. They have common risk factors, including age and comorbidity like diabetes and hypertension. They have common outcomes, cardiovascular events being very, very high. The incidence is very high in patients with both CKD or AKI, and kidney events, ESRD, diminished quality of life. But actually, they also modify each other such that AKI puts you at risk for CKD, which puts you at risk for AKI, and there's this never-ending cycle. So it's more of a fluid kind of concept. Now, how do you make a diagnosis of someone who's coming in with acute kidney injury? I'm sure with other kinds of diagnoses, you have to get a really good history. It's especially important in patients with acute kidney injury. You have to apply your categorization scheme, which we'll go over. And then you go by, you know, what's probably most common, and you use your deductive reasoning with some of your diagnostic tools. So remember that classification system, right? So pre-renal, I've now substituted the term with hemodynamic phenomenon because I feel like pre-renal, a lot of people misunderstand it as being volume depletion. And you don't have to have volume depletion all the time to get a pre-renal AKI, right? So you can have it in the setting of severe heart failure where you're actually not volume depleted at all. You're effectively volume depleted, but you're actually very volume overloaded. Same with hepatorenal. So anything that's interfering with renal perfusion is what is known as hemodynamic or quote-unquote pre-renal causes of AKI. Intrinsic phenomena, you just look at the components of a typical glomerulus or subunit glomerulus, which is this bunch of nice arterioles, interstitium, which is the space between tubules, the tubules themselves right here, and the small blood vessels. These are the blood vessels that feed the capillary loops that make up the glomeruli. We'll go over each one. And then there's plumbing, right? There's mechanical phenomenon, obstruction, usually post-kidney, whether it's in the ureter, bladder, or bladder outlet. So let's talk about the pre-renal hemodynamic phenomenon. Obviously, hypovolemia is a common cause, whether it's gastrointestinal, urinary, or skin, hemorrhage. Third spacing, I'm not so sure about, to be honest with you. And in my mind, in this table, this is misrepresented. This shouldn't be in the pre-renal group. It should really be here where you have decreased affected renal perfusion. You also see this kind of pre-renal azotemia with not so severe sepsis, where the kidney is still being perfused enough, where there's no structural damage. You also see it with hepatorenal syndrome, and we'll go over those separately. Finally, things that cause vasoconstriction or obstruction of flow to the kidneys can also give you a pre-renal picture until they make the transformation is severe enough to structural damage. So low perfusion pressure is the theme here for you have a question?
I do.
Yeah.
So all causes of renal kidney injury, are they all associated with Algeria? Is it
That's an
possible that
interesting
renal
question.
infection is
Yeah.
their output?
So I mean, it's the answer is yes. They are associated with oliguria for the most part, but the renal response is it's really hard to diagnose pre-renal azotemia of someone coming through the hospital, just because it's hard to get that history of oliguria from a lot of patients. And by the time you see them, the venas and the urine outputs have already been somewhat altered by what we do to them in the emergency room, which most of the time appropriately. But I would say if you have a severe case of pre-renal azotemia, it should be associated with oliguria. But I only say severe because there are milder cases where oliguria is not present. Oliguria being the strict definition of which is less than 400 cc's of urine output per day. That's a pretty severe form.
Right.
So what happens in the urine findings of someone with hemodynamic renal disease or pre-renal azotemia? A whole lot of nothing. But I ask you to pay attention to the urine osmolality. Can anyone tell me why the urine osmolality is very high there? Well, because you have ADH release in response to the high baroreceptor firing, right? So what is happening is that vasopressin is activated to hold on to free water and to act as a pressor if you have hypotension at the same time. And in so doing, it acts as an agent that increases free water reabsorption in the tubule, which renders your urine osmolality very high. And then with fractional excretion of sodium, I'm sure you guys are aware of this, but basically the kidneys react to volume depletion with increase in sodium reabsorption in the proximal tubule and decrease in sodium excretion in the urine, right? The problem is the kidneys only know one maneuver, and when they see decreased renal perfusion, they interpret that as being volume depleted state. It doesn't matter if it's a cardiac output problem or the patient's actually drowning in fluid. The kidneys can't tell the difference. They really weren't designed to take care of 80-year-olds with severe heart failure, right? If you think about our origins, seriously, like hunters and gatherers, they were really designed to hang on, to map mean arterial pressure and perfuse our brain and our hearts. So that's their reaction to every decreased renal perfusion that they see. And that's why the PMX goes down like that. That's a bane of existence for a lot of heart failure providers. They hate that reaction of the kidneys to the decreased renal perfusion because it makes their job much harder because they have more volume to deal with. So a nice segue, cardiorenal syndrome is a pathophysiological condition in which the heart failure causes renal failure, which causes heart failure. And it does involve decreased renal perfusion and a maladaptive vasoconstrictive response that I just reviewed. But I don't know if you can see that well, sorry. I'll just go over it. It turns out things are much more complicated. Things are always much more complicated than once imagined. And it turns out that it's not just the decreased cardiac output and decreased perfusion. There's an element of increased venous pressure at the level of the kidney, actually, that more and more we're realizing when we diurese these patients, they actually get better. Because with increased renal perfusion, increased venous pressure on the other side of the kidney actually decreases GFR, and when you relieve that pressure, GFR once again is established. There's all these things that we give these patients with heart failure, including ACE inhibitors and diuretics that can cause direct kidney injury, sympathetic activation, RAS activation. Those are some of the maneuvers that the kidney knows to employ in a decreased perfused state. And then there's also more and more evidence that other things are happening, immune-mediated as well as inflammatory-mediated stuff is happening. And I'll just make a comment. This is a little bit of a busy slide, but there was a lot of epidemiological literature coming out in the early 2000s when I was a young attending that seemed to indicate that if heart failure patients had even a bump of 0.2 in their creatinine during the hospitalization, that meant really bad prognosis. So I think that probably has to do with the fact that an AKI episode most likely increases some inflammatory state that's both bad for the heart and the kidney. There's a lot of theories around this, there's a lot of basic science literature around this, and it's just something to keep in the back of your mind. The more you can, the more you can avoid AKI, the better. So with every renal ischemia reperfusion injury, there's all sorts of maneuvers that occur, the culmination of which is renal tissue hypoxia. And when we once thought that a prerenal episode was benign and if you recover from ATM, it's benign, you're fine. Now we're realizing more and more, actually, there's long-term disadvantage to that, and that may explain some of that long-term mortality data that we saw earlier. And some of the things, long-term effects could be tubular damage and vascular rarefication that can lead to chronic renal failure, not to mention remote organ changes, such as the heart. And what's happening at the level of the mitochondria in the cells during a prolonged or severe period of hypoxia is, as you can see, as the oxygen tension is going down, you have nitric oxide buildup, and you have increased formation of these oxygen-free radicals, and you have increased apoptosis and cell death, which have permanent effects. So I just want to say a word on hepatorenal syndrome. There's this club known as the International Ascites Club, and this is how I envision them. But they meet every year in Europe, and they come up with different ways of defining kidney injury in the setting of liver failure. And they probably would be very mad at me if they think this is the picture that I use for them. But not to spend too much time on this, but essentially the whole notion of hepatorenal syndrome has changed dramatically since I trained, and where once, people thought that any AKI in the setting of liver cirrhosis or liver failure is hepatorenal syndrome. It turns out actually that's not the case, and I'll show you in the next slide. But the latest iteration of the International Club of Ascites defines that type 1 hepatorenal syndrome has to be the doubling of initial serum creatinine to greater than 2.5. Don't ask me where they got this number. In less than 2 weeks. And it occurs in the setting of acute deterioration of circulatory function and associated with a poor prognosis. Type 2 hepatorenal syndrome, which is, I believe, a real entity, is a more indolent path to renal failure. Serum creatinine greater than 1.5, don't ask me where they get this. Steady or slowly progressive course associated with refractory ascites. In 2012, they decided, you know what, maybe we don't know exactly what's going on. This is the International Club of Ascites. So they met with the AKI group, the AKI network, and they decided, let's talk about this, because there's all this new literature coming out about how AKI is a marker of badness. And they spent 3 years debating, I'm not kidding, they spent 3 years debating and came out with this article that is much more inclusive now of the concepts involved with acute kidney injury occurring in the setting of liver disease. And as you can see, there's lots of overlapping syndromes that are occurring. Functional, in this case, you can think about as hemodynamics, which is defined that without structural renal phenomenon. And then acute kidney injury can involve structural renal disease like ATM and glomerulonephritis, can involve obstruction. The point is that it's a much more inclusive way of looking at things, and hopefully those consults coming from liver that come and say, oh, this is HRS no matter what, are becoming, I think, much more considerate of all of these possibilities. The truth about HRS, as it turns out, is also a lot more complicated than we once thought. We used to think it's purely hemodynamics, blank vasodilatation, decreased renal perfusion, and the rest is just like cardiorenal and pre-renal. Turns out there's a lot more inflammation going on because there's gut bacterial translocation, which is increase in endotoxins and TNF, and that's contributing to the hyperresponsiveness of vasoconstrictors. Finally, I think this is an underappreciated phenomenon in cirrhosis and fulminant hepatic failure, and that is the cardiomyopathy that occurs in these syndromes And what that does is, because the heart is not able to compensate for the circulatory failure that is evolving, makes the syndrome even worse. And then you have the kidney kind of responding in the way it does that I described, to decrease renal perfusion with your increase in the sympathetic nervous system and the renin-angiotensin system, and ADH or vasopressin, but you also have inflammation contributing from all of these other factors. Fine, let's move on. Take a breath. We're done with hemodynamics. Now we're going to move into structural or intrinsic causes for acute kidney injury. So as I said, you can just think of this categorization, you can think of the different components that make up a nephron. Those different components are small vessel, which we'll start with. Small vessels include arterioles and capillary loops. And then the glomerulus is this entity, which is all the capillary loops with podocytes and the mesangium and tubules and interstitium. So what are some small vessel etiologies for AKI? Atherembolic phenomenon, malignant hypertension, which causes what? Turn it back on you. Malignant hypertension causes what? If you were to look at a slide of a kidney biopsy, what would that look like in a patient who has developed acute kidney injury from malignant hypertension? Anyone? Who cares?
Arteriosclerosis.
Okay, that's good. I mean, so with chronic hypertension, you definitely get arteriolosclerosis, and someone, I'm sure, who has malignant hypertension comes to the hospital, they probably have an element of that. But guess what? It looks a lot like TTP, and it looks a lot like HUS, right? So it's a thrombotic microangiopathy. The difference is where you have blood clot or thrombotic elements that are blocking the capillary loops. In the case of malignant hypertension, you have dead endothelial cells. Okay, so these are all classified as thrombotic microangiopathies, okay, including malignant hypertension. So that's one entity, and where this is a normal glomerulus, a beautiful normal glomerulus, you can see the nice open capillary loops here, and here, and here. What happens with thrombotic microangiopathy is you have these small clots blocking those normal, nice capillary loops. In this case, this is a patient with thrombotic thrombocytopenic purpura. So what about, that's it for the small vessel small blood vessel diseases as causes of AKI. What about the glomeruli? I would argue that with glomerulonephritis, you don't usually see AKI. With garden variety glomerulonephritis, you shouldn't see AKI. What you see is an indolent development of kidney injury over weeks to months, unless you have something called rapidly progressive glomerulonephritis. And rapidly progressive glomerulonephritis is also called RPGN, which is also known as crescentic glomerulonephritis. Okay, and that's a pathologic diagnosis where this is the normal glomerular tuft that's taking up bone space nicely. This is a cellular crescent that's crushing and collapsing this glomerular tuft. This is RPGN. Now, what is the differential of RPGN? You can have pulmonary involvement or not, but the major differential is pauci-immune glomerulonephritis, which includes granulomatous polyangiitis, formerly known as Wegener's, and associated with C-ANCA positivity or ANCA PR3 positivity. You can get Church-Strauss disease, or you can get MPA, microscopic polyangiitis, associated with ANCA MPO positivity. And this is pauci-immune because on the immunofluorescence, there is not, there's a whole lot going on, but on the light, you see a lot of white cells coming in and invading and causing that crescent. The second form of RPGN is anti-glomerular basement membrane disease, which when associated with pulmonary involvement is also known as not goose pastures, good pastures. And on immunofluorescence, you have IgG deposition on the glomerular basement membrane. It's that beautiful ribbon-like pattern. And then the third classification is any cause of glomerulonephritis, if severe enough, be it lupus, be it IgA, be it MPGN. If severe enough, it can cause RPGN. Okay, so RPGN is really a severe form of glomerulonephritis with different etiologies. Any questions on that? It is really important as a nephrologist to pick up on RPGN because what you do within a couple of days is extremely important in terms of the renal prognosis. So acute GN, you get moderate to severe proteinuria with hemoglobin and the dipstick. You get red cells and red cell casts when you spin the urine. And the tubule, I mean, the urine osmolality and FENA, they're arguing it's a lot of pre-renal because it's happening before the tubules are messed up, but I don't really go by this so much. And here's an example of a red cell cast under microscopy, I should say. As you can see, the RBCs are nice. So what's happening is your normal glomerulus in a case of indolent garden variety glomerulonephritis looks like this. It's swollen, it's angry, there are a lot of cells there, but this doesn't necessarily cause severe AKI, right? It has to look like this to cause severe AKI, which is the crescentic GN. The crescents really should be present in over 50% of the glomeruli on the slide or on the field to be called RPGN. The treatment for that is pretty involved, and we're not going to go over that. So we're moving on to the tubules now. We're still in the intrinsic etiologies for AKI. And here we are, acute tubular necrosis, which is probably the most common cause of AKI in the hospital setting. You have ischemic from hypovolemia, hypotension, or sepsis, and you can get it from toxic elements that we will go over. So here's an example of a normal biopsy. You can see that here is a cross-section of the tubules with nice tubular cells. They're plump. Here's that brush border. If you can see it, it's a little hard to see. But most importantly, the tubules are nicely abutting each other. And here's an example of a biopsy of someone with ATN. You can see the tubules are very, very dilated on cross-section. They're completely denuded. There are no cells here. And this is what ends up being a muddy brown cast in the urine. And it's made up of all the debris from dead cells and tan horse protein. And what's really happening in the pathophysiology of ATN is you're getting loss of polarity of the tubular cells such that your ATPase, which usually belongs on the basolateral surface, is now misdirected to the luminal surface, and that starts the whole cascade of problems that ends up causing cell necrosis and cell death and luminal obstruction with those casts that I showed on biopsy. And if the patient does better and is able to regain their blood pressure and hemodynamic stability, this entity has an amazing capacity to recover, as you can see, and it does so by reestablishing polarity as a last step in the cell. This is just basically a slide going over what's happening in the tubule. Here's your loss of polarity. Here are all the things that are going wrong intracellularly that's leading to apoptosis and necrosis. And here's what's happening to cause those casts to form. That is what we use clinically to diagnose this entity. Now, if the underlying condition improves, ATN recovers, and during recovery, you have those sublethally injured cells dedifferentiating and lining, once again, the basolateral basement membrane. And this is really possible because of induction of transcription factors, repair factors, and growth factors, some of which have been used experimentally to try and increase recovery from ATN. Not so successfully in humans. What happens when you look at the urine of someone with ATN is you see these pigmented granular casts, otherwise known as muddy brown casts, and you can't really rely on the urine test for osmolality and fractional excretion of sodium because your tubules aren't working. That's a simple way of thinking about it. And let's move on to other causes of ATN. So we talked about ischemia, hypotensive episodes, sepsis, hypovolemia. With toxic, you can get it from contrast. You can get it from myoglobin, which is the pathophysiology of Renal, right? You can get it from hemoglobin, where you see AKI in the setting of what? See if you're awake. Go ahead. Severe hemolysis, right? A severe hemolysis like ITP, you can get hemoglobin induced toxic ATN. And finally, you can also get toxic ATN from other agents that are used in the hospital setting, frequently including aminoglycosides and cisplatin. You can also have crystal-induced tubular necrosis or tubular demise via some of the crystals mentioned here from various agents, calcium oxalate crystals from what type of, well, if I say the word, you're gonna know, poisoning. Ethylene glycol, excellent. And what about uric acid? What entity is uric acid manifesting as the cause of, or not mediating the renal failure? What entity? Yes, very good. Tumor lysis syndrome. Now, the truth is that with tumor lysis syndrome, there's a lot of inflammation going on. It's not like it's this, super, I guess, saturated urine with uric acid that's precipitating. The truth is there's a lot of other things going on, but that is the classification. Excellent. So here are some other agents, and I'm embarrassed to say I should probably update this slide with new agents for the oncology therapies that are up and coming. We're seeing a lot of AKI with a lot of the new biologics and new chemotherapeutic agents. I'm going to have to update that, but I can send your chief resident a link to a next review article on that. So what about what's happening at the level of the tubules? Again, you get intratubular obstruction from these crystals that are then causing toxic sequelae and cell death at the level of the tubules. Okay, we're making progress. We're down to the interstitium now. The interstitium is the space between the tubules. This is not the best picture, but where the space should be very small and narrow with interstitial nephritis. It gets very infiltrated and big. And the differential for interstitial nephritis is allergic interstitial nephritis. We don't use acute so much anymore. Then you can have infiltrative diseases like bilateral pyelonephritis, that's pretty uncommon, lymphoma, sarcoid, and Chinese herb nephropathy, which is something we don't see much anymore, but when I was training, it was pretty common. So if you can look here on a normal slide, you see that the tubules are here. Here's the glomerulus, obviously. And actually, this tubule looks a little messed up, but we're not paying attention to that. The interstitium, you can see there's not a whole lot going on. And if you, by comparison, look at this interstitium, it's just so aggressively infiltrated with immune cells that it's literally collapsing the tubules here. So this is a severe case of interstitial nephritis. And what you see in the urine is mild to moderate proteinuria, some hemoglobin, but mostly leukocytes. And if you're able to see a white cell cast, you just made the diagnosis. Now, a lot of people think that if you demonstrate positive urinary eosinophils, then you can make the diagnosis of allergic interstitial nephritis. And I'm going to tell you not necessarily that this test is neither sensitive nor specific. But white cell cast on urine microscopy is the gold standard. And that's what they sort of look like. They're big cells that have a nucleus. This is not the best example, but this is what this looks like in your under urine microscopy. This is a white cell cast. And what are some agents that are associated with allergic interstitial nephritis? You have NSAIDs, COX inhibitors, which you don't see much anymore. antibiotics, all sorts of antibiotics, some of which are not even included in this slide. More and more, we're seeing proton pump inhibitors actually causing interstitial nephritis. And of course, those rheumatological diseases like sarcoid and oncological and certain infections that cause infiltration of the interstitium look very similar. So that's why the patient history becomes very important. So now we're on to plumbing.
Sorry, can I ask a question?
Sure.
Before you move on?
Yeah.
If someone has a normal UA, does that rule out any of the intrinsic, like does that inherently rule out an intrinsic cause to their kidney injury?
It's interesting. Yeah, I would say it does, strictly speaking, but I don't believe some of the UAs, you know. I usually repeat, like if I have a high suspicion, I don't believe a lot of things that happen, like, so if you have a high suspicion, I usually repeat it and I look at it under the microscope myself. But strictly speaking, if you have, in fact, we will say, what psychologists will say to each other, yeah, those bland urines would probably just further. But I would say push a little harder and get that second urinalysis, okay? Or even dip it yourself. But correct, if it's a bland urine sediment, it's hemodynamic.
So does AIN often get masked as like an infection if you're supposed to see pyuria on the UA?
Not really, because with an infection, you shouldn't see acute kidney injury unless you have a solitary kidney or you have a transplant. Right? Because it has to be bilateral to cause acute kidney injury. The other kidney should compensate.
So you will have pyuria on like the UA for AIN.
You will have sterile pyuria for AIN and some of those infiltrative diseases. But if the patient comes in with AKI and happens to have a UTI, I see what you're saying now. Yes, but that's not a reliable way of making the diagnosis. You have to wait to treat the urinary tract infection and then repeat. And then you just have to go with your clinical acumen to treat the patient. Okay, on to plumbing. This is easy. Obstructive causes for AKI, whether they be ureteral, including tumors, calculi, slough papillae. Retroperitoneal fibrosis is an interesting entity, actually. It encapsulates the ureters, and it causes the pressure to build up, and that causes obstruction to occur. Lymphadenopathy, same deal, and someone with severe metastatic cancer can cause encapsulation of the ureters. Bladder neck tumors, thromboemboli, calculi can also cause obstruction. They probably need to be bilateral, meaning to cause AKI. And then urethral, the most common of which I'm sure you know is BPH, but also strictures, tumors, and catheters that get blocked. That's obvious. Here's just the pictorial representation of some of what we talked about where the obstruction can occur, whether it's the urethra, the bladder neck, or the ureters. This is what obstruction looks like. Obviously, very dilated calyces and renal pelvis. It should not look like that under normal circumstances. Here's the capsule, and these should be much smaller over here. So post-renal AKI, some congenital causes such as posterior urethral valves or UVP junction obstruction. And then in acquired causes of obstructive AKI, you have BPH, we talked about it, prostate cancer, neurogenic bladder, obstructive stents, and extrinsic compression, which we talked about. Okay, we're done with the differential of how to diagnose AKI. Let's talk about outcomes. We touched upon this earlier, but I want to go back to why AKI, why some people think AKI is associated with such bad outcomes. And there's this notion that when you have a bout of AKI, there's all sorts of inflammation that's transmitted to other organs. And you know, this is a school of thought, certainly, that hasn't been proven in any way, but it's an interesting way of thinking about it. It has been shown in some animal models, such that when you induce AKI in animals, what you see is these changes in these other organs, the most common of which is the heart, TNF-alpha, IL-1 neutrophil trafficking, apoptosis, fractional shortening, So what they're doing is they're clamping the renal arteries of these animals, and then they're going to the heart and checking what's happening there 2 days later. And same with the liver, the lungs, and other organs as well. So there's this notion, there's this inflammation that gets transmitted to other organs. Maybe that's why AKI leads to such crazy long-term outcomes, including CKD and end-stage renal disease. This was a little bit shocking to us in the renal world because up until, I would say, 2004, 2005, we thought a bout of VTM was benign if they recovered back to normal. So more than 50% of patients in the ICU who developed acute kidney injury actually died before hospital discharge. Of those who survive, up to 33% require long-term dialysis. Maybe that's part of the reason. Okay, finally, we're at the home stretch here. Let's talk about treatments for AKI. So pre-renal, it sounds obvious, but maybe not. It's not really easy to establish volume status in patients, but once you do, you initiate prelude resuscitation and you watch for that increased urine output. It's a beautiful thing. If there's no increased urine output, then you stop. You don't keep giving them fluid and you reassess the situation to see, is this really pre-renal azotemia from volume depletion? In the case of pre-renal without hypovolemia, such as in the setting of heart failure, you want to treat the heart failure actually with inotropy and diuresis if indicated to help improve forward flow. I remember I was a junior attending in the CSICU and I got called for a heart failure patient. And I remember, I don't know what I was thinking, but in the recommendations I wrote, improve forward flow. That's my recommendation. And the CSICU attending was so pissed at me. Like, really? I didn't suggest we do that. Anyway, so that is the treatment. And for patients with liver disease, actually there are more options for patients with cirrhosis and hepatorenal syndrome. And, you know, kudos to the International Club of Ascites for having some of these tools available. So in Europe, they use terlipressin. For patients with HRS type 1, we don't use that here because, you know, it's associated with digit ischemia and nose ischemia of all things. So a good substitute is vasopressin. We sometimes do start people we suspect having HRS on vasopressin. Midodrine octreotide with albumin works, and sometimes TIP works as well. So what about ischemic ATN? I wish I could tell you we had something. Yeah.
I have a question.
Yeah.
Regarding like ascites, patients with like refractory ascites that are on beta blockers versus resistance, is there like some kind of controversy around that? Because you can precipitate like hepatorenal syndrome. Is that the case, or?
Yeah, I mean, there's controversy around hepatorenal syndrome no matter what angle you look at it from. But certainly, to answer your question, when you are a patient with type 2 HRS, which is the indolent one where you just have refractory ascites and you're sitting at home swollen and uncomfortable, but not in severe renal failure yet. Remember, they had that cutoff of 1.5.
Yeah.
Then you would try and treat them with the beta blockers and with the diuretics to, first of all, keep them compensated, right? And then, second of all, to, I guess, keep them comfortable. But it just takes that one injury, for example, a GI bleed or peritonitis, or even an episode of hypovolemia, if you remember, like the inciting factors for type 1 HRS, to turn you from a type 2 HRS to a type 1 HRS. And that physiology changes suddenly, and it's very dramatic. And when it goes from type 2 to type 1, all of a sudden you have circulatory failure. And what you need to do is keep circulatory hemodynamics in a way that you can perfuse your kidneys. That means getting rid of the beta blockers that can potentially worsen the cardiomyopathy in this case, right? Because you're in a state where you're hyperdynamic. You just need to increase forward flow. And you also want to stop the diuretics because they can act as vasodilators in this case too. So I would say if you're a type 2 hepatorenal and compensated and kind of walking around with a creatinine around 1.5, the beta blockers and the diuretics are keeping you compensated. Also spironolactone they use a lot. But as soon as you make that transition hemodynamically, where your blood pressure really drops and you enter that loop that is type 1 HRS, you need to stop those agents. Give them albumin, albumin, albumin. That's like also, you give 2 liters of albumin and then you wait. I can give you a HRS lecture if you want. Or maybe the liver guys want to do it. Okay. I'm not sure if that answers your question. Yeah, I would say in the setting of severe AKI, you need to stop any agent that's going to compromise the liver enzymes. So for ischemic AKI, I wish we had something. We really don't. We honestly do not. And the mainstay is supportive, which is a nice way of saying, you know, we sit around until the patient gets better. If they don't get better, then we give them dialysis. You know, aggressive nutritional support obviously is good. You don't want to keep giving them nephrotoxins if in fact that is the cause, or if not, you just stop the nephrotoxins. And then dialysis really is a way of supporting them until they get better. Dialysis does nothing to improve kidney function, right? It's just supporting, replacing the function of the kidneys until the patient gets better. And with post-obstructive, obviously, you do the extraction, however way you can, or you put in nephrostomy tubes, and the principles of treatment look otherwise similar to intrinsic AKI with the volume status and the potassium and so on and so forth. You do have to watch out for post-obstructive diuresis, especially in these patients who come in with severely dilated bladders who've had BPH and haven't been able to void for a few days. That looks a lot like nephrogenic AKI. And the reason is because of the pressure buildup, you don't have your medullary kind of gradient to be able to reabsorb water to establish your concentration gradient that you need to concentrate your urine. And then what are the indications for acute dialysis? Intractable hyperkalemia, electrolyte problems, unresponsive to conservative measures, including severe metabolic acidosis, symptomatic fluid overload, symptomatic uremia, pericarditis, CNS symptoms. There was a guy in the ER, did you put the line up?
I didn't put it in.
What's that?
I didn't put it in, but.
I thought you looked familiar, yeah. He was this young guy who had like crossed the desert from El Salvador to immigrate here, and he was, I've never, like, it's been a while since I saw someone that he was like flailing around, really out of it. Felt so bad for him, poor guy. Does anybody have him? He maybe, I don't know where he was, but.
He's a nice.
No, he was transferred a few days ago. I think he has some weird COVID-associated myopathy. It turns out he had rhabdo, actually. And ID is very interested in him. They want to try convalescent antibodies and so forth. Anyway, and then your choice of modality, you can choose hemodialysis, peritoneal dialysis. We only used here during the COVID craziness, but we usually don't use peritoneal dialysis for AKI. We use it because we didn't have enough machines. It was horrible. It works, but not great. And then continuous therapies like CVH or other types of continuous renal replacement therapy. I don't want to belabor the COVID story too much, but I wanted to just show you a couple of slides on our experience with COVID. I don't know if you know, but the kidneys may be the second, if not, well, third, if not the second organ most affected by coronavirus. And there have been some biopsy studies that show direct involvement of the virus into the kidney parenchyma and a podocytopathy. It attacks the podocytes apparently. It can also attack the tubules directly. But most of the, pathophysiology rests around the inflammation that is induced from the virus, and the inflammation is severe, and it can cause severe kidney injury, like the septic ATM picture. In our experience, this is a paper published here. And remember, I talked to you initially about the rates of AKI in the hospital. So look at this. We compared AKI incidence here during COVID with those who were COVID positive compared to historic control. And look at how much more AKI we saw in the hospital during COVID than last year at the same time. And also look at how much our RT-dependent AKI we saw. This is renal replacement therapy or dialysis, as compared to our control group from a year before. So this was a devastating period for the nephrology service. We saw a lot of kidney disease and severe kidney disease at that. And while you look at this and you say, well, not all of them had RRT dependence, and in fact, there weren't as many who left the hospital RRT dependent as there were historically, right? Except that that's because most of them died once they got to that point. So this actually got a lot of accolades, this article. It was interesting. Here's some predictors of stage 2 and 3 AKI that we put in a predictive model, and these look very familiar, and as it turns out, they're not much different from predictors of stage 2 and 2 and 3 AKI in the general hospital population, actually. There's nothing special about COVID per se when it comes to predictors. And then this is how we as a service kind of dealt with the onslaught of the COVID craziness. You know, we tried to give them as much dialysis as possible. There were some infection control considerations. We got creative with CRT and prolonged intermittent renal replacement therapy. Then we started an acute peritoneal dialysis service where I was going around doing the exchanges. I don't know if I ran into anyone here. And then medical, we just put everybody on potassium binders, looking for the best to try and conserve. So that's it. That's all I have. Any other questions? So I'll share a copy of this if you want. We can put it on one of these desktop.